Hello. I see people are starting to come in. We'll give it a few more minutes while we're waiting for attendees to come in, and we'll probably aim to start in about 3 or 4 minutes. While we're waiting, I'll just mention too that ABS is having their GYN workshop, which will be February 8th through 10th in Frisco, Texas. Looks like it's actually going to be only live, but registration is open now. And so please, if you're interested in attending that meeting, please go ahead and register. And we'll give it another few minutes for people to log in.
Professor Mutyala, do you want to mention the Q&A
Yes,
tool that we
yes.
have?
Yeah, so either we do have a Q&A method. So for questions during the talk, we'll essentially probably answer all questions at the end, just because that works a little bit better in the Zoom format. But you can enter the question through the Q&A format. That's what we kind of prefer. If not, the chat also works fine. But if you look at the bar above us, there is next to the chat is the Q&A button where you can enter the question. It works a little bit better because it allows us to see which ones have been answered and which ones not. So while chat is just kind of a free text version. But either way, we should hopefully be able to address any questions you guys have. Probably we'll make about another minute or two, and then we'll go ahead and get started. And for those of you who didn't hear earlier, I'll mention again, the ABS GYN workshop is available to register. It will be February 8th through 10th in Frisco, Texas. This year, we're running it only live. And so if you wish to attend, you can obviously please attend, and the registration is open as we speak. Okay, we'll go ahead and get started. Looks like we have some people that are all here. I mentioned earlier, please try to enter your questions in the Q&A session. There's a button right next to chat on the bar on Zoom, and we'll answer all the questions we can at the end. Ideally, we'll finish the talk around 12:45, 12:50, which will then allow 10 to 15 minutes to answer questions. But otherwise, thanks for joining. I'm Subhakar Mutyala. I'm a radiation oncologist in Arizona at the Arizona Center for Cancer Care. I'm also faculty at University of Arizona College of Medicine, Phoenix. My co-panelist, I'll let him introduce himself.
Hi, my name is Christopher Tien. I'm one of the physicists over at the Yale School of Medicine. I'm also an associate professor and the lead physicist at the School of Medicine.
All right, well, and thank you, ABS, for hosting this webinar, and we'll go ahead and get started. For disclosures, neither of us have any disclosures. I do want to mention, though, we will talk about commercial products and vendors through this talk, but that does not necessarily say we are endorsing them. Obviously, in brachytherapy, when we talk about applicators, they are made by vendors, and so we will mention those during the talk. Now, here are the objectives we'll talk about. Essentially, we'll kind of hit some of the background of skin cancer itself and where and why we are doing brachytherapy for skin cancer, and then kind of hit some of the basics of brachytherapy: electronic brachytherapy, flat applicators, mold brachytherapy. And the goal of this webinar is essentially to kind of present to you guys, if you have a brachytherapy machine or are interested in having one, then how can you start a skin brachytherapy program? And we're kind of hitting some of the basics of that. And then with talking about some of the mold applicators, and we are going to kind of hit some of the more advanced techniques for it. But definitely this will kind of give a brief overview of if you're going to start a skin brachytherapy program, what are some kind of nuts and bolts to know about it. And then at the end, I'll kind of hit some of the clinical experience. I will talk about my experience. I am in Arizona, which is a very sunny state, and we'd have a ton of skin cancer. And previously to this, I was in Texas, which is not that dissimilar. And so I'll talk at least about my experience and some of the publications that have been put out. So we have a good idea of what the published experience is talking about for brachytherapy. Now, first, we'll talk about the background, the epidemiology and the historical perspective of brachytherapy. Skin cancer is really, really, really common. There are more skin cancers than there are all other cancers combined. Now, this is important for us to know because as radiation oncologists, we do treat some skin cancers, but sometimes we don't always jump on skin cancer as one of our main treatment areas. Everyone thinks breast, prostate, that's our bread and butter. But looking at this graph, we need to start thinking of skin cancer as one of our most important treatments that we are doing. They've sort of stopped calling it non-melanoma skin cancer and kind of started calling it keratinocyte carcinoma. Now that's, like I said, one of the most common skin cancer, one of the most common cancers in the United States, with 3 million of those being diagnosed per year. High in incidence and prevalence. Basal cell carcinoma is the most common, with squamous cell carcinoma being the second most common. Merkel cell is very rare, and the amount of basal cell and squamous cell that are out there completely dwarfs melanoma. Melanoma, there's 70,000 melanomas per year, and we're talking about 3 million basal cells and squamous cells per year. So the amount, the sheer volume of keratinocyte carcinoma is massive, and that comes back to the point I was saying, as radiation oncologists, we need to consider this one of the main cancers that we do treat. Now, the incidence has been rising over the past few years. This data is actually not from the United States, it's actually from Scotland. Scotland, majority of the population is slightly more fair than at least me, but it is rising. Our population is aging. We are actually having a lot more immunocompromised people, whether they're cancer survivors or transplant patients. They're immunocompromised and they develop a lot of skin cancers. Plus, as people are just getting old, they're naturally aging makes you a little more immunocompromised. So both basal cells and squamous cell incidence is rising in the world. Realistically, we do have to keep in mind that skin cancer does occur in sun-exposed areas, and so of course in the face and arms and legs is the most common places where we see these. Now, the treatment, realistically, the mainstay treatment is surgery. I'm kind of going to go over this briefly because I know I'm speaking to people that know all this data, but surgery is one of the main treatments. It is essentially a local disease, and so surgery can be used to definitively treat the cancer. Surgery includes full thickness excision or Mohs surgery, and both of those have 95% or so tumor control rates. For less aggressive cancers, you can use cryosurgery, electrodesiccation and curettage, or chemical peels. Radiation therapy is also a treatment for it. For very small early in situ cancers, sometimes you can also use topical 5-FU, but surgery is still the mainstay. Now, one important thing to know from a practice building standpoint, as surgery is a treatment for keratinocyte carcinoma, the dermatologists are the ones who diagnose the cancer and can also treat them. So it's important to know that for every patient we treat with radiation, you are taking a patient from the dermatologist, and so building that relationship is important so you can run cases by the dermatologists, because they're the ones who diagnose the cancer, yet they also do offer a viable treatment, kind of similar to urologists in our prostate cancer treatments. Now, talking about the historical perspective, we have over 100 years of data for radiation use in skin cancer. So the first treatment of skin cancer using superficial X-rays at that time was just called Röntgen therapy, was in 1898. The first time a cancer was treated using brachytherapy was in 1901, where a radium source was just placed on a skin cancer and put there for a few minutes. Now, realistically, that's how we treated all cancers until the development of Linacs and megavoltage in the 40s. And since that happened, then the use of brachytherapy for skin cancers had gone down significantly. But that is one of the, that was actually the initial cancer that was treated with radiation. So it's important to know that radiation's been used for skin cancer for several years. Now, here's a picture of how it was first treated. Like I said, they took a radium source, placed it there. As you see in the picture, Dr. Danlos did not have any shielding. I don't know what shielding he would have even worn. He's holding radium, which is in the megavoltage range, and it's a very dirty energy spike. But yes, this is how it was treated. Pretty positive he didn't have an IRB or anything along those lines too, but it worked. Now, as our techniques did get better at the Memorial Sloan Kettering, they started using these radium slugs in a mold, and when we started having some dosimetry involved, then you could see how a mold was used to place over a certain area. And so you see as our techniques have improved over the years, where we are just, instead of just placing a source over a skin cancer, we can actually start having some sort of a dosimetry. Now, radiation, as I mentioned, brachytherapy was the initial treatment for keratinocyte carcinoma, but as the advent of Linacs and electron beam, external beam has been the major treatment for skin cancer since then. Realistically, radiation has a very high cure rate of 90 and 95%, possibly even higher, and we'll go through some of this data in more detail as we talk about brachytherapy specifically. Radiation is an alternative to surgery. As I mentioned, surgery is the mainstay and the gold standard treatment. That being said, surgery is not always a viable option for patients. For some older patients, they maybe have anesthesia risk, and doing surgery is not really a viable option. For cosmetically sensitive areas, as I mentioned, it's in a sun-exposed area. Operating on the nose and ear can be very disfiguring. Also in the scalp, where you don't always have skin to close. And so for these areas where surgery is just not a good option due to morbidity, then radiation is a very reasonable option. Or recurrent disease after surgery, where a second surgery might not be a viable option, or adjuvant therapy if there's high-risk disease as PNI or positive margin, and again, surgery might not be an option. These are all indications for radiation after where radiation can be used for keratinocyte carcinoma. Now, the options for external beam, historically, we used to have orthovoltage X-rays. That's not that common in America these days. I actually decommissioned my last orthovoltage machine in 2010, and I don't know how many manufacturers are actually making them. One of the reasons we decommissioned it is we couldn't get any parts for it. And once it broke down, we couldn't repair it. And so I don't know if any vendors are actually making orthovoltage X-rays realistically. So electrons have been used mostly for treatment of these small superficial treatments. And I'll kind of show why electrons can work in some situations and why they can't. MV photons obviously can be used. That actually has a much more depth of invasion, and there'll be certain patients that would need to receive the MV photon radiation. Now, for brachytherapy, that includes HDR in this country, which is the most common. PDR and LDR is not really used that much in this country, but can be used in other countries, definitely. And electronic brachytherapy, which is used around the world too. In this presentation, we will touch on electronic brachytherapy, but mostly we'll talk about HDR brachytherapy. Now, the reason HDR brachytherapy can have an advantage over external beam radiation therapy, which includes electrons, it can be given much more hypofractionated courses. So as I mentioned, some of these patients are elderly. Maybe transportation is not the easiest thing for them to have. So coming for 30 fractions of electrons might be difficult. So maybe doing a shorter abbreviated course with brachytherapy might benefit the patients. Also, it has a faster dose fall off. And so even with electrons, there's going to be a reasonable bit of subcutaneous tissue that receives radiation. And definitely if you're using photons, you're going to treat a lot of tissue below the tumor. As I mentioned, these are only local diseases and very superficial. And so the dose fall off from brachytherapy actually has a benefit in terms of not only tumor control by giving a high dose superficially, but also for improving cosmesis. Now, here's just a picture of superficial or ortho voltage, just for completeness to include it. As you can see, it is done. You can always use, topical shielding to kind of shape the beams. But as I said, in this country, I don't think there's any manufacturers that are making efficient ones too, and this one definitely is not being made anymore. Now, I touched on electron beam, and here's just the reason I'm including this picture is showing situations like this are perfect for electron beam, where it's flat, we can control the dosimetry, and the depth dose is not super high. Now, unfortunately, well, as I mentioned, most of these tumors are on the face or sun-exposed areas on the hands and arms. As you know, at least my face doesn't really look like this. And, an ear or nose is definitely much more geographically complicated than this, flat solid water bath that we're showing. And so in those situations, yeah, there are places maybe somewhere on the temple is going to be flat and can work great, or somewhere on the torso, but anywhere on the nose or ear, it's a lot more difficult to shoot an electron beam. And then on top of that, dosimetry, when you get to very small areas in your electron beam, your dosimetry gets a lot more narrowed and are more bullet shaped, and all those isodose curves, instead of bowing out, start bowing in, and you start losing some of your dosimetric advantage of electron. And so that's where through good patient selection, brachytherapy would be a significant benefit over electrons. Now, to shift to talk about brachytherapy, obviously the main topic of our talk today, when is brachytherapy appropriate? So there is a good ABS consensus guideline, which came out in 2020, and they had a previous one published in 2015. So I would advise everyone to get both of those articles. And if you're starting a program, patient selection is of the utmost importance. And so initially, you should try to stick to small skin cancers, 2 centimeters or less, and a depth of 5 millimeters or less. Anything more than that, then you could use photons or electrons, and you might not need to have all the benefits of the quick dose fall off of surface brachytherapy. Patients that you should not treat with brachytherapy, at least initially, when you're starting a program, is ones that have bone invasion, because you definitely do need to treat a lot deeper. And, the bone could be less than 5 millimeters away, especially if you look at your zygoma, you notice, or even off your scalp, sometimes it could be only 4 millimeters away. So that the depth doesn't just tell you that there's no bone invasion. If there's deep extension, and sometimes initially starting, maybe don't jump on the young patients, mainly because if there's any cosmetic issues, then you definitely don't want to end up having those on younger patients. Excuse me. So this is a picture from the consensus guideline of which patients are appropriate for brachytherapy. Excuse me. So if you see here, for electronic brachytherapy, or if you're using some of the flat applicators, which we have plenty of pictures later in the talk, you really want to have a smaller PTV and not that deep, meaning that 5 millimeters might even be too deep. For electronic brachytherapy, the energies are fairly low, 50 to 60 kV. So if you're going to treat something deep, your surface is going to get really hot, and you really don't want that. For your flat applicators, your prescription is usually about 3 millimeters or so. And when you start going below that, you don't have the same optimization options you can with the mold applicators. It'll make sense a little bit further on when we show some pictures about that. And this chart is pulled directly from the consensus statement. Now, to talk about electronic brachytherapy, one of the initial electronic brachytherapy was a Zoft, and there's a decent number of publications based on the Zoft platform. And a huge advantage of this platform, if you're starting a program, is it does not involve a massively shielded vault. As you can see here in the picture, they're delivering this treatment in the CT simulator room. Because essentially it's 50 kV, it's all essentially self-shielded, and it goes direction of the applicator. So this is a very simple way to start a program without a lot of capital investment, especially if you don't have a radionuclide afterloader available. This is another commercial product from Elekta called the Estea. It also produces I think it's 68 or something like that kV that also can be delivered in an exam room or CT sim room. And you can see here where a patient is just placed here, right here on the exam table, and the treatment is delivered right there. So real simple way to start a program, especially if you're not thinking about doing more complicated brachytherapy programs, and a radionuclide afterloader might not necessarily be needed. Now, to kind of shift over to flat applicators, I'm going to turn it over to Dr. Tien.
All right, thank you, Professor Mutyala. So as you can see, there's a wide variety of brachytherapy applicators available for skin. I'd like to kind of go into the Leipzig style applicators. Obviously, they were developed at University of Leipzig in Germany, and they've made it across the pond to fairly common usage over here. I think most institutions would consider this to be kind of the bread and butter for skin brachy. If you have an institution that only has a basic skin brachytherapy program, this is what you're going to see. And that's because they are kind of the easiest and most consider actually the most useful applicator for skin brachytherapy. There are kind of two vendor versions of the Leipzig applicators. The original design is kind of I don't want to mention vendors, but the original design is on the left, and the different vendor design is on the right. As you can see, they look a little different just in general, but the basic components they're still the same. So you have the metal cone and a stem which leads into it, and during treatment, the source will travel to the inside of the cone, and usually it's a HDR iridium source. It'll come to the center of the cone and deliver the dose. You can't really see it on the left, but the cone is hollow on the inside, so you could see it on the picture in the right. You'll also notice that on the design on the left, there's two orientations. For the Leipzig, you can either have the source come in horizontally, or it can come in vertically. And these actually have two huge major dosimetric implications. We'll get to that in the next few slides here. If you look carefully, you'll see the set on the left has a special white cap, and that's a buildup cap to reduce electron contamination and super low scatter that wouldn't contribute significantly to the PTV dose. So there's that cap's not always available for each vendor. There are other modifications and caps, and the next slide shows one of those. It's called the Valencia modification and developed University of Valencia. It's essentially a tiny flattening filter, and that's used for the horizontal orientation only. So let's get into the dosimetry here. So what we have here are the applicators with a vertically oriented stem. They show a dip in the dose near the central axis, and that's because anisotropy. Excuse me. And then the high dose region is actually far away from the central axis. Whereas with the horizontally oriented, the high dose is going to be right in the center. For each type of collimator, each type of applicator, there's different collimators available. They range from 10 to 45 millimeters. But we've noticed that even with the largest collimator, due to the rapid dose fall off, the 90% isodose line is only limited to about a 1 cm diameter area at the 3 millimeter depth, which is the most common treatment depth. So commonly you'll see these nomograms that are given out, and they look quite impressive in terms of dose. But if you look really carefully, you really need to zoom in to see the 3 millimeter depth, and that shows the useful treatment area, and it's only like 1 or 2 cm. So sometimes it can be a little deceiving, and you really need to zoom in on make sure you're commissioning the right area here. And the other thing to point out, you can't really see the legend on here, but the 90% line is what you're looking at, and I believe that it's the one smaller than the red, so it's green down here. So it's pretty tiny. Um, and yep. So we'll get into that dosimetry in a second. in the next slide. So as you noticed before, the isodose distribution is actually pretty small. So it limits the usefulness of our Leipzig applicator. So we've found that in order to widen it, we could do two things. We can take the source and put it, instead of just at the center, we can put at the end and the edge of the applicator cone, and that kind of stretches it from subpanel B to subpanel C. And then we actually have taken it a step further, and we've modeled out what it looks like if we take the source at the edge, irradiate it, and then flip the entire applicator around 180 and then irradiate it again. So we're getting up to 3 cm of useful area at the 3 millimeter depth. And so this actually fits really well for scars that are a little bit longer than instead of a small punctate lesion. We have not used this clinically. This is just a research kind of treatment planning study. This slide is also nice because it shows an example of a 3D rendered model, and that's available in all treatment planning systems, the commercial ones. You can see there's a source, there's the cup, there's the stem, and the densities are pre-programmed in. So that's equally important for two reasons. One, you have the metal. Two, you have the air. And three, now you have the actual patient. So obviously, the metal throws a huge wrench into the considerations for dose, but also the air does, because we're moving really far away from our typical TG43 based calculations of dose. So this is no longer an intracavitary type of situation where you have what you could argue to be an infinite medium of water or 30 cm block of water, like you have an intracavitary. And now you're talking about losing backscatter because you're directly on the surface of the skin. So can we go to the next slide? So I mentioned earlier the Valencia modification, and it contains a flattening filter, and it flattens out dose distribution, so you can increase the treatment area from the 90% isodose line. But because you have the flattening filter in there, you reduce the dose rate by significantly, you double the dose rate, or double the dose time. So that can be a practical concern. The other thing with this is, and we're going to talk about this later, you need a special kind of dose calculation algorithm, which can be either Monte Carlo or model-based dose calculation. And that is another big consideration before you implement it clinically. The other option is you can get these pre-printed nomograms like we have here, and then you just look up a depth, and you look up the width, you figure out the dwell time. So there's two kind of approaches to it. Next slide. So we will talk about the typical fractionation and the outcomes at the end of the presentation. But typically we're looking at 42 gray, 6 to 7 fractions. So in a typical treatment, definitely less than 10 minutes, even if you have a cold source. The majority of the time and most important thing is spent in the setup. And so on the next slide. So some vendors have developed a template with like a clear center, and they have marked out, pre-printed the diameter of the Leipzig or Valencia applicator, and they allow you to mark the position and determine if the margins are appropriate. So what you do in this situation is kind of plug and play. You find a punctate lesion that you try and target, you put the template down, you center it, and then the outline you can use to center the cone, because the cone's not transparent. So you can't see exactly where you're aiming at unless you have something that kind of guide that. And we've seen studies where there's actually significant deviations in the dose that we intend to deliver versus the dose that we're actually getting. So we highly recommend using templates, at least for the first few cases, so you get a feel for exactly what's going on. Obviously, you can use markers, and everyone uses markers, but we find that this is a little bit better of technique because it really centers the crosshair. And we saw how sharp the gradients are at the edge of the treated area.
Yeah, so to come back to talk about the mold brachytherapy, so the flat applicators work great. But again, that's if you have a flat tumor. As I mentioned, you know, the nose and the ear are very common places where this could happen, or even fingers and hands, where sometimes the flat applicator might not work. And so mold brachytherapy is something that can be done, which uses the same concepts of all the brachytherapy we're talking about, but just actually kind of can mold and shape it for certain angles. So flaps are something very simple, and all vendors have a version of this: Ham applicator, Freeburg flap. They all have different commercial names, but basically the main benefit of these applicators are it actually puts your catheters at a certain distance from each other, and so they're parallel, even if you're molding it and shaping it, and also gives you a fairly standard distance from the source to the surface, including over complex curvatures. You can sew them into masks or use them in thermoplast, aquaplast material for something that's reproducible, or you can place it just directly on the patient themselves. And here's an example of a small flap applicator placed on a surface. With these also, you can do a CAT scan and do a fully graphically optimized plan, as opposed to all the planning that Dr. Tien was just talking about, where most of it is done just as a hand calc, and unless you have a good model, you're not really doing a plan on the patient. With the flap, you can totally do a plan per patient on exactly where it is. Now, with that, you know, when you're taping the flap here, that's not always going to be as reproducible. And so if you're really going to do a 3D optimized plan, usually I would advocate to say, you know, place it in aquaplast or thermoplast, you know, below it and on top of it. I'll show some pictures on how that can be done. But then that's essentially exactly very, very reproducible each time the patient comes in. Other areas you could treat: ears are actually very common places to where patients do get skin cancers, as that's even if you wear a hat, your ears are usually sun exposed still. Now, they're very complicated in terms of curvatures, and definitely electrons are very difficult to treat there without treating a very wide area of the patient's scalp. And so a custom wax mold using a J-loop, just a catheter that's kind of runs around, and you can choose where it needs to be treated per the patient. That's a simple way to treat it. I have some other pictures of a custom-made applicator that I use myself for an ear a little bit later. A custom mold can be just made with catheters and aquaplast beads or anything else. You can do it to go over any shape. So a scalp or the frenulum right there is easily treated using a custom mold. Traditionally, these are all handmade, but recently with technology, they can now be starting to be 3D printed. But it actually is custom formed to the patient's skin, and it actually allows it to be reproducible. Now, the distance between the catheter and the skin and the distance between each catheter, that's going to kind of depend on the person who creates it, and also what material is used, which can influence some dosimetry. As I mentioned, traditionally they've been all handmade, but now we can actually have 3D printed molds. And here's a study of a 3D printed mold done from a patient where their nose is treated here. Here you can see this is where the skin cancer is. The 3D mold is printed with the holes for the catheters placed in the 3D mold. And here you can see how the dosimetry is very nice and conforming to just the tumor and the depth that it needs to be, and very minimal dose beyond it. Here's another pilot study. This came out of Sunnybrook in Canada. And this is a 3D printed mold, again, with the different catheters. In this article, they specifically mentioned they chose to print it with clear resin. So you can see when it's placed that it's actually flush with the skin. Another thing in some of the handmade ones I did is I always made sure there were holes in it in some way or form so you could see the skin to know that it goes on the skin. But if you look here at the dosimetry, and they did it dosimetry for 2 different orientations, and you could see how the dosimetry kind of curves right through your PTV area and very minimal dose beyond it. Now, there are commercially available versions of this where you send in the DICOM of the CT, and then you get the 3D printed mold. This is sort of the same technology that's used for those 3D printed bolus that you can get custom made for noses and ears and other things like that. They're just printed with hollows for the catheters, and then catheters are placed in. And again, once you do that, then you can scan the patient, do a completely 3D graphically optimized plan, and then you really know where your dosimetry is. And then because this applicator is rigid, it's going to be very reproducible each time the patient comes in for treatment.
Sorry, I had to unmute. So we've seen the commercial printing applications have come in, and there have been institutions that sort of, they sent their contours, the same dosimeter send the contours in for printing, and they come back. The first set is perfectly fine, and then the next patient, same dosimetrist, same contour creation method, they come back and they don't fit. And so there's this excellent study by Beleda, and they noticed that the window level actually makes a huge difference, and that's the culprit. It makes a huge difference on the patient comfort, conformality, and as you could see before, there is a huge difference, and it's crucial to actually get the patient set up in the same way. So go. So now we get to the meat of the physics involvement. The model-based dose calculation algorithms are kind of the choice for using treatment planning system for your actual dose calculations. So generally, they're done with TG43, TG43U, and then this applicator or this algorithm assumes water equivalent. Everyone already knows that. But what we usually do is we do our calcs with TG43 because it's real time, and so it's really interactive in terms of covering the PTV. And then we go back and we recalculate with a model-based dose calculation algorithm. And then we compare the results and make sure that the physician is reasonably happy with the difference in the dose. Now, there is kind of like a big viewpoint difference here, because we notice that the backscatter is lost. So we know the dose is a little bit lower than what's calculated by TG43. But all of our clinical data up to this point is calculated with TG43. So our clinical outcomes are based on TG43. So we know that there's a good correlation between, let's say, this dose and this type of isodose and a certain clinical outcome. And the bottom line, we're looking for a clinical outcome. We're not looking for accurate dosimetry. So in general, what we usually do is we pad up the dose a little bit because we know we're going to lose that backscatter. The Valencia and the Leipzig are made of tungsten. So the air cavity, the tungsten, we require the model-based dose calculation algorithm if we want to get the full rigid calculation of the geometry and scatter. You could also use Monte Carlo. That's not very clinically practical, but a model-based dose calculation rhythm is perfectly acceptable, feasible, and accurate. There was a report by TG186. This is almost 10 years. It's more than 10 years old, which reviews model-based dose calculation algorithms and kind of gives recommendations for dose specifications, commissioning, uncertainty, limitations. They don't provide an explicit recommendation on whether they should use TG43 versus model-based, and that's understandable. So this is a big clinical decision that the brachytherapy program, when you're developing, if you're going to use your treatment planning system to calculate your doses, that's a big decision that you need to make. We're happy to report that the working group on dose calculation algorithms, brachytherapy, they released report 372, which is quadruple consensus report. So AAPM, Estro, ABS, and ABG. And so I think it took 4 years to get through. I mistakenly put in the wrong reference. It's 2023. Dr. Vihande is very, very happy that it's out. And so it gives you a very comprehensive commissioning kind of handbook, side by side. You just look at it with your computer, treatment planning system. You download the source, you walk through it, and you're all set to go. It's very, very bulletproof, well-written report. So another source guide, another consideration was source guide tube placement. We realized quickly that you can come up with different source guide tube orientations, and one of our main clinical considerations for our team is to minimize the contact of the guide tube and minimize the amount running over the patient. We know the transit dose is low, but we want something to minimize that as much as possible. So that's just something to keep in mind when you're building your molds or creating custom kind of applicators for this situation. So if you have a nose, for example, you don't want it to run over the entire body, over the head. You'd rather have it just come from above the head and maybe a couple cm over the top of transit area.
All right, to now talk about the clinical experience and some of the data that's out there. We mentioned earlier, this is the ABS consensus statement, which came out in 2020. If you notice here, the doses are all over the place. And now realistically, all of the data is essentially all single institution stuff. And there's not really been a consensus. So some of the initial publications with the Leipzig in this country, with Michael Casper, we're using the 42 gray in 6 fractions or 7 fractions. Some of the initial Zoft publications were using 8 fractions of 5 gray. One of my publications was also using 5 gray times 8 or 3 gray times 16. And so there are publications kind of all over the place, but at least gives you a good guideline of a simple place to start, as long as you kind of are relatively either using a published dose per fraction One of the reasons I chose the 5 gray times 8 was because it was published using electronic brachytherapy previously. Or you can do a BED conversion just to know you're still getting your EQD2 of 60-ish gray, which we know is what is needed for our skin cancers. A couple years before ABS published their recommendations, JEC Estro published theirs also. And so again, this is I'm including this just for anybody that wants to pull it up for some background. As we mentioned, Leipzig and Valencia are both in Europe, so there's some more publications from there. And you can see again the dose is a little bit all over the place with the number of fractionations and a dose per fraction, in addition to a certain number of depth of millimeters of prescription. So I can at least talk about one of my experience. Most of the times I've done either 5 gray times 8 or 3 gray times 16. And the prescription dose is to 3 millimeters depth. And then either I'll do a tumor plus 5 cm or so for margin. And then for PTV, possibly another expansion, possibly not, depending on the applicator. Essentially, I would use custom-made molds using a ham flap that's built into the thermoplast. If you see this picture here, as we kind of were mentioning about the surface of it, what we notice is when you kind of make these molds, sometimes you don't know exactly where the surface of the skin is. And so here we actually place some barium paste just on the skin, so it's clearly obvious when you scan on where the aquaplast thermoplast ends and where the skin begins, and then usually just kind of wire the area. This area is a little bit large because this was a adjuvant case where the patient had extensive PNI. And so basically we used the scar plus about 2 centimeters margin. We created a custom aquaplast mask of them, placed the ham applicator on top there with catheters through it, and then placed another piece of aquaplast thermoplast on top of it. And then we essentially have Velcro around to place it over there to hold it in place for treatment. At the time of creation and sim, we actually have this plastic eye shield, and then we replaced that later with lead. Although in this situation, actually, we didn't end up treating with it because actually the dose was higher with the lead there, just from the angle. And then we do scan the patient and then do a graphically optimized plan. So we published on our experience in 2018. We actually had about 273 lesions on 172 patients. This is one of the larger series that's published, but like I mentioned, most of them that are published are single institution series. Over 3/4 of them were 5 gray times 8, and then the other 1/4 was 3 gray times 16. And we had about 2-year follow-up median. We had a little over 95% local control. And if recurrence came back, the median time for recurrence was 9 months. Our acute toxicity was about 50% got grade 2 or higher, but 40% of that was essential, or 30%, 40% were grade 2. And then we had 12% grade 3 and 5% grade 4. Now, all of those healed, but we did have about 4% chronic ulcers, which persisted, and about 60% of those resolved using either hyperbaric oxygen or some other treatment. And all of the chronic ulcers were in lower extremity. And so on the face, it seems the tissues are very, very well perfused, and healing will happen pretty well regardless of the patient's age. But the lower extremity is a little bit more dangerous just due to the lack of blood flow in some of our elder patients. Here's a couple of pictures. If you could see here, this patient actually had previous surgery and a skin graft right here, and he recurred right at the edge. And so the surgeon thought it would be difficult to add another graft that would heal to that graft. So we ended up treating this using this technique. Here's the dosimetry with 3 catheters, and you can see how the dosimetry is just, hitting the area that we need to treat very well. And picture here is the acute toxicity, and then how it healed afterwards. Here's an ear, and for this one, we ended up making a custom mold using aquaplast beads and dental putty, and we ended up using it. It's kind of like a clamshell, and so we had some catheters on one side and catheters on the other side. And here you can see the dosimetry kind of just treating the ear, but you can see here the scalp, and the rest of them receives no radiation. And here's the outcome of the ear. Now, for just to talk about the outcomes in general, like I mentioned, they're pretty much all single institution series, but pretty much all of them have a greater than 95% control rate, which is similar to Mohs or full thickness resection. There hasn't been a really good meta-analysis or any large multi-institution series yet, unfortunately. Now, secondarily, the cosmesis is excellent. The endpoints are not really cosmetic in most of these series, including ours, but in all of the outcomes, we should study this better, but the cosmesis, I would venture to say, is actually better than electrons. And I think because there's less depth dose, there's less subcutaneous tissue getting radiation, so there's less fibrosis and retraction of the skin. So I think the cosmesis my hypothesis is the cosmesis is better using brachytherapy. In terms of toxicity, I mentioned about 40% grade 2 toxicity, and that's kind of mentioned across the board. There's a pretty good publication from Canada, Europe, and America. Phil Devlin, Amar Tagar, and Alex Stewart are the authors, but they actually talk about the toxicities of skin brachy. There's usually 10% greater than grade 3 radiation dermatitis, but usually the majority of that heal. Now, it seems like there's less than 5% chronic ulceration that is present. And so lower extremity seems to be a kind of a dangerous place to give these higher doses with the brachytherapy. And so our practice, we kind of changed it and give a lower dose on the lower extremity, or sometimes even use just electrons in lower extremity if needed, using conventional fractionation, just due to trying to avoid a chronic ulcer. Now, this is the last slide that I'm including, essentially, is just the Patterns of Care study that was published in 2017, just to show that of the people that do use skin brachytherapy, at least in 2017, people were using all of these applicators. Leipzig, flaps, custom molds, Valencias, and electronic brachytherapy. Electronic brachytherapy obviously is a little bit less frequent because that's for certain practices. But for people that use a radionuclide afterloader, you can have all of these. Currently, I do use a Leipzig, Valencia, and flap applicators for my patients. Now, in summary, brachytherapy is a suitable treatment for keratinocyte carcinoma, as long as you actually have very good patient selection, and it does seem to have very good tumor control with minimal toxicity. There are various ways to treat patients with this using electronic brachytherapy, Leipzig-style applicators, custom flaps, Valencia molds. Some are commercially printed, some you can make yourself. And the dosimetry is important, as Dr. Tien did mention. And for more information, there's the ABS consensus statement, the JEC Estro consensus statement, APMTG 253, and all these other publications for you guys to reference. Thank you for your attention, and we will take any questions that are available. And please use either the chat or the Q&A.
Just real quick, so this webinar will be recorded, so if you decide that you want to check out the references, I know we kind of ran through them pretty quick, then they're available for your at your leisure.
So I'm not seeing any questions yet. Please ask them. We have another few minutes for this webinar. All right, so I do see some questions. So the first question is there an estimate for what percentage of patients with lower extremity lesions developed ulceration instead of just the overall population? So, you know, when we analyzed our lower extremity data, that's a very tricky question, because realistically, all the patients we get have poor circulation there, because usually extremities can be operated on. And so you already have a selection bias of patients that have poor circulation in the lower extremity. So I would venture to say it's a higher percentage of the patients you see if you're seeing ones that already have a lower extremity vasculopathy. So I would say a higher percentage just because of the selection bias that you have. Do you alter margins based on clinical scenario or site? Yes. Any consideration for deep margin coverage? Yeah, there is some publications about using like a ultrasound to get a depth. But in general, I kind of use, for a simple basal cell or simple squamous cell, I would typically do a 3 millimeter depth. And then the margin based on clinical scenario, yeah. Might do a little slightly wider margin if patient's like a transplant patient and they have a squamous cell, because those might be a little more concerning. It might do a slightly wider margin, or if they have extensive PNI or something concerning along those lines.
Yeah, and so also along those lines, the reason that the 3 millimeters depth is commonly used is because we're 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 limited by our dosimetry, and the skin dose at the actual surface is around 150, 175% if we're getting a D90% coverage at 3 millimeters. So anything above that, we're starting to get very hot, and it's definitely a clinical decision by the physician.
So another question is any difference between severe acute toxicity between electrons, photons versus HDR brachy? And also, does HDR brachy heal quicker than electron photons? There's not a lot of data out there about that. When you look, even realistically, the publications on electrons for skin brachy, the publications are fairly slim too. The assumptions is they're probably about the same. We did present some data on, I did present some data on a match pair analysis of superficial X-rays and HDR brachy, and also of electrons and HDR brachytherapy, and it actually seems to be about the same in terms of the grade of toxicity. In terms of the time, we didn't actually study the time on how quickly it came up or not. With HDR, it seems to be lagged a little bit. Meaning it doesn't, a lot of times doesn't happen during the course of radiation, but happens shortly afterwards. But I don't think that has been studied well at all. How many fractions a week for HDR brachy? Actually, for the 8 fractions of 5 gray, typically I did 2 fractions a week. And then for the 3 gray times 16, I did 4 fractions a week. I have no data on why or if what's better or worse. That's just what my experience is and what we did. But I'm not, there's no comparison data to say 5 grays with 8 fractions straight through versus twice a week is better or worse. But that seems to be the convention in the publication. Sorry, go ahead.
So don't quote me on this, but I think the ABS and GEC-Astro have the summary, and it does give the fractionation like timeline. So it does give you the number of fractions per week if you want to look at that to kind of develop your own clinical workflow.
There's one question, Dr. Tien, if you want to answer on what do you use for commissioning of the applicators?
Yeah. So for commissioning of the Leipzig, there's a specific kind of ion chamber, and there's a jig that goes along with the applicator, and we'll basically center this end-on ion chamber with the center of the source, and then we use that to get our physical measurement. We compare that against the treatment planning system, and we compare that against the instructions for use provided by the vendor.
So one question is, if the lesion thickness is greater than 5 millimeters, when will you choose EBRT versus interstitial brachy? I mean, realistically, I think that comes down to the patient. So if these are a very elderly patient, and they're anesthesia risk already, and that's why they're not having surgery, it might be hard to do interstitial brachy for the exact same reason. But clinical correlation is there. So those patients, I would end up using I would end up using EBRT with photons or electrons for those patients if they can't undergo anesthesia for interstitial brachy. And I think that's all the time we have. Thank you all for attending, and thank you, ABS, for hosting. Thank you, Dr. Tien, for co-hosting.